Right, let's get straight into it. We're going to critically appraise the BASIL 2 trial. Now, its full title is an absolute mouthful. A vein bypass first versus a best endovascular treatment first revascularization strategy for patients with chronic limb-threatening ischemia who required an infrapopliteal with or without an additional more proximal infrainguinal revascularization procedure to restore limb perfusion. Let's just break that down, shall we?
We're going to tackle this systematically, exactly as you would in your Viva. We'll start with the PICO statement to properly frame the question. Then we'll assess its internal validity, take a deep dive into the statistics, pull out the key results that really matter, consider the external validity, and finally, deliver the verdict. Okay, first up, the PICO statement. Let's precisely define what the trial was actually asking.
So, the population, we're talking about patients with chronic, limb-threatening ischemia from atherosclerosis. They all needed an infrapopliteal revascularization. But here's the crucial bit. They had to be deemed suitable for both a vein bypass and an endovascular procedure.
The intervention was a vein bypass first strategy. This predominantly meant using the patient's own great saphenous vein, usually coming off the common or superficial femoral artery.
And what was this compared to? The comparator was a best endovascular treatment first strategy. So think primarily balloon angioplasty, with the selective use of bare metal stents, drug-eluting stents, or drug-coated balloons when needed. And finally, the outcome. The primary outcome was amputation-free survival. Now, this is a key point. It's a composite endpoint. It's defined as the time to the first major amputation, so that's above the ankle, or death from any cause. And this was all analyzed in the intention-to-treat population.
Right, PICO done. Now for the appraisal. How robust was this study? Let's assess the internal validity, the quality of the methodology.
So, what kind of study was it? BASIL 2 is an open-label, pragmatic, multi-center, phase 3 randomized controlled trial. It was a big undertaking run across 41 different hospitals in the UK, Sweden, and Denmark.
We'll assess the methodology against these key points, just like you would in the exam.
The inclusion criteria are a really critical point of discussion. Insisting that every patient had to be suitable for both strategies is great for internal validity. It means you're comparing like with like. But, and this is the key insight, it also selects for a very specific, high-risk and comorbid group of patients.
Randomization was done using minimization. This is a smart technique that actively balances the groups for key prognostic factors like age, diabetes, renal disease, and the extent of tissue loss. It's a good way to reduce the risk of any allocation imbalance from the start.
Now, the trial was open label, and you have to mention this. Realistically, it was unavoidable. You can't blind a surgeon or a patient to whether they've had a big bypass operation or a small puncture in the groin. But you must acknowledge that this does introduce the potential for performance bias.
Adherence to the assigned treatment was actually very high, 84% in the bypass group and 95% in the endo group. Crucially, the analysis was performed on an intention-to-treat basis. This is the correct way to do it, as it preserves the integrity of the original randomization despite any crossover. Follow-up for the primary endpoint was excellent, although the pandemic did disrupt some of the secondary outcome data collection.
So, with a pretty solid methodology in place, let's dive into the statistics and see how they actually interpreted all this data. The primary outcome, amputation-free survival, was analyzed using a Cox proportional hazards model. That's the standard for this kind of time-to-event data. And importantly, it was properly adjusted for those minimization variables and also for the recruiting center.
In that model generated an adjusted hazard ratio of 1.35.
So what does that number actually mean? Well, a hazard ratio greater than 1 indicates a higher event rate. So, in this case, the vein bypass first group had a 35% increased risk of reaching that primary endpoint, major amputation or death, compared to the endovascular first group.
Now, let's look at the 95% confidence interval. It went from 1.02 to 1.8. The absolute key here is that the interval does not cross 1. That's what tells us this is a statistically significant result. However, look how wide that range is, from just a 2% increased risk all the way up to an 80% increased risk. So yes, it's significant, but there is a lot of uncertainty about the true size of this effect.
The Kaplan-Meier curves really show this visually. You can see a clear and sustained separation between the two lines over time, and that separation favors the best endovascular treatment first strategy. It's also worth noting that the pre-specified sensitivity analyses all pointed in the same direction, which adds confidence to the result.
Okay, Enough with the stats. Let's boil this all down. What were the headline findings you absolutely need to know?
The main conclusion is crystal clear. A best endovascular treatment first strategy was associated with superior amputation-free survival when compared with a vein bypass first strategy in this specific group of patients. Right, now this is the single most important point for your exams. The difference in that primary outcome was largely driven by fewer deaths in the endovascular group. It was not driven by a difference in limb salvage. In fact, if you look at the major amputation rates, they were almost identical between the two groups, 20% in the bypass arm versus 18% in the endo arm.
And what about other procedures down the line? Well, as you might predict, re-intervention was more common after an endovascular treatment. But interestingly, crossover, that is, needing the other strategy later on, was more common from the vein bypass group.
So now that we have the results, we have to consider external validity. How can we apply these findings, and what are the important limitations and caveats? This is the key question every good clinician asks. Who do these findings actually apply to?
And the answer is very specific. These findings apply to CLTI patients with infrapopliteal disease who are considered good candidates for both strategies. You absolutely cannot just extrapolate these results to all CLTI patients, especially those whose disease is limited to the femoropopliteal segment.
You'll almost certainly be asked to contrast this with the BEST CLI trial. The key differences to remember are BASIL 2 focused specifically on infrapopliteal disease and used amputation-free survival as its primary endpoint. BEST CLI included a wider group with fempop disease and used a different endpoint, major adverse limb event or death. These differences are vital to understanding why they reach different conclusions.
And you must acknowledge the major limitation. The trial was stopped early because of the COVID-19 pandemic. This means it didn't reach its planned sample size or target number of events. This underpowering is the reason we saw that wide confidence interval, and it just increases the statistical uncertainty around the findings.
Okay, time to bring it all together. The final verdict. What is the definitive take-home message?
In a nutshell, BASIL 2 is a practice-changing trial for patients who have chronic limb-threatening ischemia and require an infrapopliteal revascularization.
The conclusion is clear. For patients who fit the criteria, an endovascular first strategy should now be our preferred approach, and this holds true even when a perfectly good quality vein is available for a bypass.
Now, this doesn't mean vein bypass is obsolete. Far from it. It's still a crucial tool in our toolbox, but it should no longer be considered the default first-line strategy for this specific group of patients. It's now more of a selective, or perhaps second-line option.
So, the final verdict for your examiners? Despite its limitations, particularly being stopped early, BASIL 2 gets a clear pass for its methodological quality and its incredibly high clinical relevance.